Merhabalar herkese.
Hello everyone. The speakers before me talked about mode of action, technical issues and side effects. Okay, so this is a technique and mode of action. We now know what they are, but what are the clinical ramifications? How do we select the patients? In what fields do we use it? So I'll generally give you some information about these points. I'll try to do basically a review of some studies. I'll talk about patient selection. The use of TMU in bipolar, in elderly patients, in adolescents, in pregnant women, and in neurologic disease. TMS. And this is just a general slide. We used to have some guidelines as well. This presentation, our clinical practice and the studies that we've been conducting have all been partly based on this book. That's why I have it here. This is a series of reviews. Now I know it is not possible to read, but this is a good review of some of the studies throughout the years. Now, TMS has been shown to be effective in treatment-resistant depression treatment. Its use in the world is increasing, and we also know that it is now FDA approved. That is important. Because among all the reviews that we talked about, we see that the studies mostly focused on resistant depression, which is an important subject for us. Different results have been reported by different studies, as mentioned by a previous speaker, different frequencies, different areas of the brain. Those might explain the difference, but its effectiveness in treatment has been shown. So, how do we choose a patient? When we get a patient, do we do medication therapy, ECT, psychotherapy, or what kind of a combination therapy should we use, or do we use with these patients? Where do we have TMS situated in all of this? So certain specific conditions in patients might be advantageous when it comes to TMS application. For instance, if the patient has a history of response to TMS, we know this from ECT patients. If a patient responds to ECT in the past, then the likelihood of responding to the same treatment in the future is higher, or if you do medication instead of ECT, then it has a lower response rate. So the same applies to TMS. The second important point is that in circumstances where there is an obstacle in the way of using medication, we can use TMS. In elderly patients, for instance, we have certain difficulties, or drug interactions can be problematic in this category of people, so TMS comes in handy in these circumstances as well. Or we use the medication necessary, we use the necessary augmentation and strengthening, but end up with resistance, then TMS again is the answer. Or if we have symptoms of severe depression and resistant depression, and we want to augment this treatment using ECT, but there might be certain circumstances which rule out ECT, and TMS, again, is a good tool to have in the clinical setting. Now, the studies have focused on a number of issues, and FDA approval, again, is in the field of resistant depression, but there are other studies for other psychiatric conditions too. Now, I'll try to give you a summary of these studies. In bipolar, for instance, there's only a restricted number of publications about the use of TMS in bipolar. When I say use in bipolar, but bipolar depression and bipolar mania, of course, both periods. In bipolar depression cases as well, TMS has actually been shown to be an effective option. Concomitant mood disorders do not reduce, or should be reduced in such a way as not to reduce the efficiency of TMS and not to allow a new episode. So the selection should be meticulous. To give you an example from some of these studies, this particular one, for instance, they had bipolar patients, and they had low-frequency stimulation on the right prefrontal cortex, and response rate was higher, compared to other groups. This group has 20 patients, 20 sessions of active practice or sham practice. In the active arm, there has been a statistically significant improvement in depression. This study had 23 bipolar depressive patients, and they had 5 Hertz stimulation and sham stimulation on the DRPFC, and active stimulation did not demonstrate any significant recovery. In the low-frequency right DRPFC practice, 6 patients out of 11 responded to treatment, 4 achieved remission. The good responders at the end of the 12th month in monitoring, they also had a good status. Another study, 19 bipolar depression patients, a new coil was used to have a deeper impact, and brain stimulation was done through TMS, and response rate was found to be higher than 60%, but in this study, 1 case had a generalized seizure. Another study. Before proceeding with this one, I'd like to say the following. In studies, generally speaking, the intensity, and the region of application can lead to great differences. If you have high frequency to the left or to the right, number of sessions, these all can lead to different changes. And the differences in outcome of these studies have actually stemmed from these parameters. Therefore, in the studies I outlined for bipolar, there are different results, yes, but the conclusion parts of these studies have always highlighted these parameters. In bipolar depression TMS patients, mania phases have been reported, but this probability is actually low and no higher than sham. 4 of these reported cases were actually our cases in the meantime, and 2 of these patients had bipolar history in the family, so maybe only medication would have led to a manic episode even if we hadn't added TMS, but it could also have been triggered by TMS. Early studies have shown that TMS can be used to treat mania as well. Gökben was saying that it can cause epilepsy, and it can be used in the treatment of epilepsy, so it depends on the region of the brain, the high Hertz or low Hertz frequency that you use. These all determine the effect you get. So it can be used in bipolar depression, but during also the bipolar manic episodes. But in the manic episodes, we use high frequency on the right dorsolateral prefrontal cortex, and when compared to the left, the right seems to be more effective in reducing mania symptoms. There's another study, more recent, sham-controlled 141 patients, right area high frequency has been shown to have an anti-manic effect. So generally speaking, when it comes to bipolar, the studies indicate that while the majority of TMS studies focus on unipolar major depression, in patients with a history of manic episodes, mood regulators, when they are used, you have to pay particular attention. And the use of TMS for mania symptoms is an area that needs further studies. Elderly patients is a group with which we have difficulty in clinical practice. In depression, they might have resistance to treatment. That's an important subject for elderly patients. Antidepressants and increasing combinations and drug-drug interactions are also a common problem in these patients. This is a study with 49 elderly patients, median age 69. Dose variable low-frequency TMS was implemented. Significant reduction in depression symptoms, and response criteria was obtained into treatment in 9 patients. In another study, no difference was observed between active and sham stimulation. However, this treatment was very short, only 5 days, because our treatments usually are planned over 15 to 20 sessions. This was only a 5-day study and the dosages were really low. Another small study, 24 patients were treated for 10 days with low-dose treatment, and active and sham were compared with no difference. In elderly patients, when you apply TMS, the problem is, compared to younger patients, they do not have comparable degrees of response to TMS. In the frontal area, compared to the motor cortex in elderly patients, the scalp cortex distance is larger, and this means that the magnetic stimulation penetrates at a lesser degree according to certain researchers. In the motor cortex and frontal cortex, there are differences in scalp cortex distance. When that is factored in and stimulation is increased, Nahas and co-workers found that in their study with 18 elderly patients, with these strengthening, they obtained response in 5 patients out of 18. Another study, 20 patients, only 6 did not respond to treatment, and TMS treatment was not correlated with age in this study. In another study with 130 patients, again, no correlation between clinic response and age. So in elderly patients, generally speaking then, treatment-resistant depression is widespread, and other treatment methodologies are hard to apply, and we need more randomized controlled trials in this field. If this kind of support is brought, then TMS can be a more viable option, a tool that will make life easier for us in treatment. Let's have a look at adolescents. TMS utilization is an area in which there is very limited information when it comes to adolescents. There is one study, for instance, 2 weeks left DLPFC received high frequency and certain response rates were achieved. With relatively lower stimulation, 2 adolescents responded to treatment out of 3. 2,000 pulses were used on 2 adolescents and the response was observed. We rather have case reports with adolescents, not clinical studies. A third case series had 5 cases, 400 pulses were used in 14 sessions of TMS, and 3 of the 5 patients had meaningful, significant treatment response. In a 16-year-old girl, first treatment led to generalized seizure. No predisposing factor was defined. It was not a tonic-clonic seizure, but it was more of a syncopic seizure. In this age group, compared to other age groups, the seizure threshold can be lower, and those who implemented TMS said that in those with previous syncope history and with people with low threshold of seizure, you have to be more alert when applying TMS. Pregnancy is another period which can cause us problems in our clinical practice, especially the first 3 months and the first trimester. If we have depression in a patient and if psychotherapies have not worked, then it can be a problematic case for us. ECT treatment, for instance, if you don't have something so severe that you would need ECT, you can find yourself in no man's ground. When it comes to TMS during pregnancy, let's have a look at some of the studies. The first case was reported in 1999 by Nahas and co-workers. It was a 36-year-old woman, second trimester, anxiety, depression. TMS was implemented on this woman, and during TMS, blood pressure, heartbeat, oxygen saturation did not display any abnormalities. There was recovery and improvement in depression, and the baby was born in term and healthy. Another study, 3 cases, early pregnancy, depression, TMS was applied. Not that much information when it comes to the details of the technique, but the researchers did not find any damage to fetuses in these 3 cases and said that this could be a good treatment option in depression. Kulirova and co-workers had 15-session TMS on 16-week and 31-week 2 pregnant women, found that depression improved more than 50% and the babies were born healthy. Kim and co-workers focused on 10 pregnant women, second and third trimester with depression, applied 20-session TMS and 70% response was achieved to treatment. No significant side effect was observed in the pregnant women and the fetuses. A moderate headache at 40% is the most frequent side effect and it's transient only. And in pregnant women who do not want to receive antidepressant treatment, TMS can be a promising treatment option. Another study with a large sample, pregnant women with depression accepted psychotherapy the most frequently. TMS is actually a treatment modality that is not accepted by almost any of the pregnant women, but once they watched an informative video about TMS, 15.7% of participants started seeing TMS as an acceptable option. Another study, Burton and colleagues reported a case after pharmacotherapy and 2 sessions of TMS treatment. 4 years of maintenance TMS was applied to a patient, and when the patient got pregnant, during pregnancy, maintenance TMS was still applied. During pregnancy and postnatal period, no medical complication was observed and signs and symptoms of depression improved, and therefore the use of maintenance TMS during pregnancy was saw as a viable option. We also had a patient, we reported actually that as a case. 20 sessions of TMS was applied during pregnancy. We obtained response to treatment and we followed the patient up. The depressive mood had fluctuations, and once we observed that, we did weekly TMS until birth. I think we applied about 35 sessions. And functionality and depressive mood-wise, everything was okay and the baby was healthy in that case. Let's have a look at the final category, neurological disease situations. Now, depression can be a comorbid situation to neurologic diseases. For instance, in Parkinson's, depression is quite frequent. In a study, 10 patients from this group received low-frequency frontal TMS, and although this was low frequency, there was a significant reduction in depression symptoms. Another study, 14 patients, high-frequency stimulation was used and significant reduction in depression symptoms was achieved. With 22 depressive Parkinson patients, 5 Hz dorsolateral prefrontal cortex TMS practice was compared to sham, and the antidepressant effect was shown. 92 vascular depression patients this time, left dorsolateral prefrontal cortex, sham and active TMS were compared. In active TMS group, antidepressant effect was significant. In a study in the post-stroke environment, 10 Hz left DLPFC small group compared to the sham group demonstrated antidepressant effect, significant antidepressant effect. At high frequencies, although there is no cognitive improvement, depression scores are improved. Thank you.